Hi, in this second part of our discussion on drugs acting on blood, we are going to look at the anticoagulants. And under the anticoagulants, we'll talk about the direct and indirect thrombin inhibitors. Then we'll also talk about the vitamin K antagonists and the class of drug known as NOAC, novel oral anticoagulants. Then from there, we'll look at the fibrinolytic agents. We'll talk about antiplatelets, drugs used in bleeding disorders. Then we also talk about inhibitors of fibrinolysis. In having a proper understanding of the pharmacology of drugs acting on blood, it's important that we review coagulation, the physiology of coagulation, and fibrinolysis. Now, what happens that the blood that is normally liquid flowing through the vessels gets to clot sometimes? What happens is that beneath the endothelial surfaces of the blood vessels, there are some proteins, and these proteins include collagen and von Willebrand factor. So with injury, there will be addition and aggregation of platelets. The platelets will bind to the collagen and von Willebrand factor on the injured vessel surface. At the same time, there will be synthesis and secretion of vasoconstrictors and platelet recruiting and activating molecules. And these platelet recruiting and activating molecules include thromboxane A2, which is a platelet activator and vasoconstrictor. Then adenosine diphosphate and 5-hydroxytryptamine, otherwise known as serotonin, which is itself another platelet aggregator and vasoconstrictor. Also, the 2B3A receptor belonging to the integrin family will undergo a conformational change, which will enable it to bind fibrinogen. And this fibrinogen will cross-link adjacent platelets, which will lead to the formation of a platelet plug. Simultaneously with these events, there will be activation of the coagulation cascade. And when we talk about the coagulation cascade, you remember there's the extrinsic pathway, there's the intrinsic pathway, and then we also should remember that both of them coalesce at the common pathway. Now look at this. With vessel injury, first there will be vasoconstriction, then there will be exposure of collagen, and with the exposure of collagen, you have platelet reactions, then activation of coagulation going ahead simultaneously with platelet activation, platelet reactions. Then under the platelet reactions, you have the formation of a loose platelet aggregation, that is from binding of the different platelets by fibrinogen. And then you have the formation of a temporary hemostatic plug. Then with the activation of coagulation, the end result of the activation of coagulation will be the generation of thrombin. And it is thrombin that will lead to the generation of fibrin from fibrinogen, leading to the formation of the definitive hemostatic plug. This next slide is showing the different steps in the coagulation cascade. And eventually, what will happen is the generation of thrombin. And then this thrombin will catalyze the conversion of fibrinogen to fibrin. Then, in a transglutamination reaction, factor 13 A will cause stabilization of the fibrin clot, leading to the formation of the definitive hemostatic plug. There are certain parameters that are used in monitoring the activities of the drugs that are used as anticoagulants. And first one is clotting time. We know that clotting time, the range is from 4 to 8 minutes. Then prothrombin time, the normal range of that is 12 to 14 seconds. Then activated partial thromboplastin time, normal range is 26 to 33 seconds. Prothrombin time assesses the activity of the extrinsic and common pathways, and it measures factors 2, factor 5, factor 7, factor 10, and fibrinogen, whereas activated partial thromboplastin time measures the intrinsic pathway. So what are the functions of this thrombin that is generated following the activation of the clotting cascade? First, thrombin catalyzes the polymerization of fibrinogen to form a fibrin clot. Then, thrombin also leads to activation of many upstream clotting factors, leading to the generation of more thrombin. It also causes activation of factor 8. It is a potent platelet activator and mitogen, and then it has an anticoagulant effect by activating the protein C pathway. Fibrinolysis, on the other hand, refers to removal of unwanted clots. And fibrinolysis is activated by conversion of plasminogen to plasmin by the tissue plasminogen activator. The tissue plasminogen activator, on the other hand, is inhibited by plasminogen activator inhibitors 1 and 2. So what happens is that simultaneously with the activation of the clotting cascade, the fibrinolytic pathway will also be activated, and the plasminogen will be converted to plasmin by the tissue plasminogen activator. We should also know that plasmin is inhibited by another protein known as alpha-2 antiplasmin. We have some natural anticoagulants, and these include prostacyclin, which is a vasodilator and also an inhibitor of platelet aggregation and secretion. Then there is antithrombin, there is heparan sulfate, then you also have activated protein C and protein S. We also have the tissue factor pathway inhibitor, which inhibits factors 10A and factor 7A tissue factor complex. So let's look at the anticoagulants. And under the anticoagulants, we have the direct and indirect thrombin inhibitors. The indirect thrombin inhibitors are heparin, unfractionated heparin, and also low molecular weight heparin. Before that, anticoagulants act by either inhibiting the synthesis of clotting factors or by inhibiting the activity of clotting factors. And the indirect thrombin inhibitors act by either inhibiting the synthesis of clotting factors or by inhibiting the activity of clotting factors. The indirect thrombin inhibitors act by binding to antithrombin to enhance its inactivation of factor 10A. whereas the direct thrombin inhibitors, just as their name implies, act by binding to thrombin. They inhibit thrombin directly. So that is why they are direct thrombin inhibitors. Unfractionated heparin also enhances antithrombin's inactivation of thrombin and factor 10A. Heparin increases the rate of thrombin antithrombin reaction by at least 1,000-fold. Heparin is a glucose aminoglycan that is found in the secretory granules of mast cells. It is a heterogeneous mixture of sulfated mucopolysaccharides and consists of polymers of several carbohydrates, which include D-glucosamine, D-glucuronic acid, and L-iduronic acid. That is for unfractionated or standard heparin. Low molecular weight heparin, on the other hand, is obtained from chemical alteration of standard heparin. Low molecular weight heparin include enoxaparin, tinzaparin, dalteparin, and others. And the low molecular weight heparins have equal efficacy with unfractionated heparin. They also have increased bioavailability from the subcutaneous site, and they have the added advantage of requiring no need for monitoring. Mechanism of action of heparin is by catalysis of the inhibitory action of antithrombin on the coagulation factors of the common and intrinsic pathways, and at least 18 monosaccharide molecules are required to be present in the heparin molecule for it to catalyze inhibition of thrombin by antithrombin. And this is why the mechanism of action of the low molecular weight heparins is different from this, as stated here for unfractionated or standard heparin. Then heparin can also cause aggregation of platelets when it is administered as standard doses. However, it's doubtful if this contributes to the anticoagulation effect of heparin. Heparin is administered either as a continuous IV infusion or through the subcutaneous route, and it is usually administered as the sodium salt, but the calcium salt is also effective. And then lithium salt is used as anticoagulant in for blood samples. Onset of action after IV infusion is about 1 to 2 hours. Is immediate. Onset of action is immediate after IV infusion, whereas after subcutaneous administration, the onset of action is about 1 to 2 hours, and the half-life depends on the dose administered. Metabolism is in the liver by the reticuloendothelial system, and excretion is through urine. The doses of enoxaparin is a low molecular weight heparin, are specified in milligrams, while for dalteparin, tinzaparin, and anaparoid, the doses are specified in anti-factor 10A units. Heparin is used, number one, for initiation of treatment of venous thrombosis and pulmonary embolism, for the long-term management of patients with recurrent thromboembolism, in the initial management of patients with unstable angina or acute myocardial infarction, also used for the treatment of some patients with DIC, can also be used during coronary angioplasty or stent placement, also used during surgery requiring cardiopulmonary bypass. Then we should also note that heparin is the drug of choice for anticoagulation during pregnancy. It's important that we remember this. And monitoring of heparin therapy is with the activated partial thromboplastin time, protamine titration, or anti-factor 10A units. Then, what happens with when there is toxicity to heparin? Toxicity to heparin usually will manifest as bleeding. So, in this situation, the heparin should be discontinued. In a lot of cases, this alone will suffice to reverse the toxic effect. However, in cases where cessation of heparin alone is not effective or does not control the toxicity, then a specific heparin antagonist, which is known as protamine sulfate, should be administered. Protamine sulfate is administered at a dose of 1 milligram of protamine for every 100 units of heparin that is still left in the patient. But we should note that protamine itself can have an anticoagulant effect, and this will cause by interaction with platelets, with fibrinogen, and with some other plasma proteins. Contraindications to the use of heparin include hypersensitivity, heparin-induced thrombocytopenia. And what is heparin-induced thrombocytopenia? This is a hypercoagulability state that develops about 7 to 10 days after onset of administration of heparin. And it manifests. What you find is that there will be reduction of the blood platelet level to about less than 150,000, or reduction to less than 50% of pretreatment values. There will be formation of thrombus, which will block vessels like the temporal vessels and other vessels in the body. And when this is discovered, treatment is to immediately discontinue the heparin and switch to a different anticoagulant. And a patient who has developed heparin-induced thrombocytopenia should never be treated with heparin again in future. Then, severe hypertension is also another contraindication to heparin. Hypersensitivity to heparin, significant thrombocytopenia, intracranial hemorrhage, active tuberculosis, ulcerative lesions of the GIT, hemophilia are some of the contraindications to the use of heparin. Then we have the synthetic heparin derivatives, and these are fondaparinux and idraparinux. Fondaparinux is a pentasaccharide based on the structure of the antithrombin binding region of heparin. It has a half-life of about 17 to 21 hours, and excretion is via the kidney. Mode of action is by mediation of inhibition of factor 10A by antithrombin. And there's no significant thrombocytopenia associated with its use. There's no need for coagulation monitoring, and it is contraindicated in patients with renal failure. The second one, idraparinux, which is a derivative of fondaparinux, has the advantage of having a much longer half-life of about 5 to 6 days. In certain instances, it might appear as if heparin is not working, and this situation is described as heparin resistance. And it is seen, number one, when there are high plasma level of certain proteins that competitively inhibit binding of heparin to antithrombin. Then when there are increased concentration of factor 8 in the plasma. Also, when there is rapid clearance of the drug, for example, in cases of massive pulmonary embolism. Then can also be seen in patients with hepatic cirrhosis, nephrotic syndrome, and disseminated intravascular coagulation. Toxicities, heparin toxicities include bleeding, thrombocytopenia, elevated transaminases levels, osteoporosis, inhibition of aldosterone synthesis, and hyperkalemia. Low molecular weight heparin, this acts mainly through inhibition of activated factor 10 and does not usually require monitoring. The differences between standard heparin and low molecular weight heparin include the source. Low molecular weight heparin is obtained from modification of standard heparin. Then low molecular weight heparin are of a shorter length than standard heparin. Then the mode of action also is different. The half-life of low molecular weight heparin is longer than that of heparin. Apart from that, the pharmacokinetic profiles of low molecular weight heparin is more predictable. Therefore, there's no need for laboratory monitoring. The incidence of osteopenia and of heparin-induced thrombocytopenia is less with low molecular weight heparins. Other parenteral anticoagulants, these are direct thrombin inhibitors, and these include lepirudin, which act by binding to the exosite 1 of thrombin and is used for the treatment of patients with heparin-induced thrombocytopenia. Daily monitoring with activated partial thromboplastin time. Bivalirudin, intravenous administration, and is used as an alternative to heparin in patients undergoing coronary angioplasty. Excretion is via the kidneys. Agatroban is a synthetic compound which acts by binding to the catalytic site of thrombin. Administration is via the intravenous route, half-life is over 40 to 50 minutes, and it is used as an alternative to lepirudin. Then the oral anticoagulants. These include the vitamin K antagonists and the NOAC, as we mentioned earlier. Here, let's first look at the vitamin K antagonists. And these include warfarin, dacumarov, phenydione, indamonidione, and anisindione. Warfarin is the most popular among these agents. It is a coumarin derivative and it acts by blocking the gamma carboxylation of glutamine residues in the vitamin K dependent clotting factors, thereby leading to the formation of incomplete clotting factors that do not have biological activity. Full effect of warfarin therapy is manifested only after several days. This is because its effect is only on the already formed coagulation factors. It has no effect on the, sorry, this is because its effect does not extend to the already formed coagulation factors. Its effect is only on the coagulation factors that are just being formed. So, because of this, the coagulation factors that have already been formed have to be completely degraded before the effect of warfarin administration will manifest. And because of this, warfarin should be commenced with heparin administration. So the two, when you want to administer warfarin, you should also start the patient on heparin and continue both the heparin and warfarin for a period of about 5 days, after which the heparin can now be discontinued and the warfarin alone continued. Though it is called an oral anticoagulant, It can also be administered through other routes. For example, it can be administered rectally or through the intravenous route. And the bioavailability is very good, irrespective of the route of administration that is chosen. The usual starting dose is 5 milligram per day for 2 to 4 days. But this dose should be reduced in the elderly and also in individuals who have a higher risk of bleeding. It crosses the placenta, and because of this, it should never be administered to a pregnant woman. The half life is about 25 to 60 hours, and metabolism is by CYP. Excretion is in urine and in stool. And because it's metabolized by CYP, then we expect that it will have a lot of drug interactions. So there's interaction with cholestyramine, with barbiturates, rifampin, azo antifungals, and several other drugs. Resistance to warfarin can be seen in one, cases of excessive vitamin K intake. Don't forget that it's a vitamin K antagonist. Non-compliance with medication, mutations in vitamin K epoxide reductase gene, and its toxicity can be reversed by administration of vitamin K1, fresh frozen plasma, prothrombin complex concentrates, and recombinant factor 7A. Toxicities include bleeding, birth defects, abortion, alopecia, dermatitis, and others. What are the uses? First, prevention of progression or recurrence of acute deep vein thrombosis or pulmonary embolism. Prevention of venous thromboembolism in patients undergoing orthopedic or gynecological surgery. Prevention of systemic embolization in patients with acute myocardial infarction, prosthetic heart valves, or chronic atrial fibrillation. And monitoring is by the international normalized ratio. Zimelaglatran is a prodrug that is metabolized to melagatran. It's also a direct thrombin inhibitor with a faster onset of action than warfarin. However, it requires to be monitored. It's administered twice daily, and there's no requirement for coagulation monitoring. And the main side effect is asymptomatic elevation of hepatic transaminases. Then the NOACs, these are the novel oral anticoagulants, and they are classified into direct thrombin inhibitor and direct factor 10A inhibitors. The direct thrombin inhibitor among the group is dabigatran, whereas the direct factor 10A inhibitors are rivaroxaban, apixaban, and edoxaban. All of them are administered orally, and their bioavailability ranges from 50 to 100%, except for dabigatran, with a bioavailability of only 6%. Half-life is about 12 hours. Rivaroxaban and apixaban are extensively metabolized by the liver, whereas edoxaban is only minimally metabolized by the liver, while dabigatran is not metabolized at all by the liver. Excretion is via the kidneys. What's the mechanism of action? Dabigatran inhibits coagulation by directly binding to thrombin to prevent the formation of fibrin. And the direct factor 10 inhibitors, as their name implies, bind directly to factor 10A to prevent it from cleaving prothrombin to thrombin. All the drugs have predictable pharmacokinetics, and because of this, there is no need for routine laboratory monitoring. Indications for these drugs include non-valvular atrial fibrillation, prophylaxis of venous thromboembolism, prevention and treatment of deep venous thrombosis, prevention and treatment of pulmonary embolism, heparin-induced thrombocytopenia. What are the advantages of NOAC over the vitamin K dependent antagonists. Number one, there is immediate onset and offset of action. Hence, no need for heparin bridging. Don't forget that we mentioned earlier that with warfarin, when you want to administer warfarin, you first have to also administer heparin. You commence the warfarin with heparin before you now discontinue the heparin after some days. For this one, you don't need to co-administer with heparin because onset of action is immediate. Then there is no requirement for routine coagulation monitoring. They have fixed daily doses. Their actions are not affected by food intake. Hence, no dietary restrictions. Then there's reduced bleeding complication. There's greater efficacy in atrial fibrillation, and they have minimal interaction with other drugs. However, in cases where you feel you want to monitor or check their activities, you can use prothrombin time, you can use the activated partial thromboplastin time, and other tests as listed here. Of course, as with everything, with every other drug, it also has toxic effects, and these toxic effects include bleeding, especially gastrointestinal bleeding. Then, some have specific administration requirements. Rivaroxaban and edoxaban should be administered with food. Then, they cannot be used in patients with severe renal dysfunction. Contraindications to their use include mechanical heart valve, rheumatic mitral stenosis, and severe kidney dysfunction. And in cases of toxicities, the antidotes to their use are idarucizumab for dabigatran, whereas for the direct factor 10A inhibitors, andexanet alpha is the specific antidote for those ones. We'll stop here and then continue at a later date. Thank you.